Hello and welcome everyone in another episode of Researcher Celebrity powered by Empowering Science Foundation. Today we have a true celebrity with us, Dr. Sushanta Kumar Ghosh. We call him Dr. Ghosh also. So a brief about Dr. Ghosh. He has done his bachelor's and master's in zoology from University of Burdwan and pursued PhD when not many people were actually focusing or thinking about doing PhD. He is the first person to do PhD from National Institute of Malaria Research during serving the country as at that time it was Malaria Research Center. So we will be going to have a great conversation with Dr. Ghosh, and you will listen that how the journey from a research scientist to scientist G, and he headed university he headed the National Institute of Malaria Research at Bangalore, that center. So I would like to say welcome, sir, at the platform.
Thank you, Dr. Raja. It is my pleasure that you have chosen me as one of the researcher celebrities under your platform. See that, I come from a family of doctors, and I was born and brought up in those days, about 65 years back. It was in a remote village in Bengal. And my grandfather, Dr. K.P. Mandal, he was the village doctor. And I have seen from my childhood how life, he has given to many lives to many people. And then that was my energy from the starting of my life. I've seen the rows of people, patients, coming, and he didn't bother about, about himself. So uh, anytime people used to call, whether day or night, and I have seen that particular, environment. And
Mm-hmm.
then my I was brought up in my maternal uncle house, and
Mm-hmm.
then my grandma was a great energy and great inspiration for all of us.
Mm-hmm.
And still, it is continuing because our still joint family we maintain, and that gives us a big, big, big boost in everywhere. And then I was amply, grown up under the guidance and stewardship my uncle, Dr. Padmasri, Dr. S.K. Mandal. He is a very
Mm-hmm.
renowned orthopedic surgeon in Gangaram Hospital in Delhi. And my
Mm-hmm.
aunt, she was the director of GB Pant Hospital in New Delhi. So under
Mm-hmm.
their guidance, I was grown and brought up, and naturally, so that makes a lot of difference in the life. So
Sweet.
things
Sir,
cannot be long
coming
on the
from
distance.
doctor's background, okay,
Yes.
being your grandfather and then maternal uncles, how and when you decided that you wanted to be a researcher?
See that, I thought that I have to, from the beginning of my life, I was something has to be done, seeing
Mm-hmm.
the sufferings of the people that, at large. Then I decided to take science. The reason
Mm-hmm.
behind is that if you do some innovations in science, not only you are, in a group of people, you will be having wider, good cause for the humanity. So at a larger scale, is a larger area of, there is no boundaries. If you think of your innovation, small innovations has no boundary, so it will be applicable to the humanities and human societies and communities. So at large, it will be very useful. That was the idea to take the science.
Mm-hmm. So, but when so the medical field must
Yes.
be very attractive for you, that you ever
Yes.
wanted to pursue medical as a like a doctor, or you were clear that you want to be a researcher?
See, the thing is that, I had, taken as a researcher. I told you the
Mm-hmm.
background why.
Mm-hmm.
And I in the that those days, it was a very difficult time in Bengal. And then I also got chemistry. Then I
Mm-hmm.
also got both subjects. I got opportunities. Then I selected geology because geology is a biological subject, and I thought to have something to do on biological science. Of course, these days there is no boundaries. Chemistry, biochemistry, and geology, everything is, there's no boundaries, so anybody can do any research on any aspects. The
Mm-hmm.
way I think the way the 40 years the science has developed, I think it is marvelous. And the last 30 years, and since the discovery of PCR by Caribbean, it has changed the entire, scientific and biological science and everything. So that actually gave, then like hybridoma technology 1975, then PCR 1990s, and then gene cloning, and then diagnostics, and all these aspects are very, very, encouraging thing. And then gene editing is a very big thing for development of science and science applications.
So let's start the journey from after your master's. That was the time when India was
Yes.
not known for very high, education, or people were not motivated towards higher education. What made you think that you want to do a PhD in the first place?
See, the thing is that, when I passed MSc, so I also got an opportunity, being in geology background, work under Calcutta universities, under a fellowship. And then, there is an opportunity in MRC, Malaria Research Center. And then I, appeared for that. And then once I got that MRC and Malaria Research Center at that time, I thought that to shift to malaria research, because malaria is one disease still, knuckling, and that is still an disease, to be tackled as a whole. And that time, India was facing a serious problem of malaria. You know the malaria history. Then by 1947, when India got independence, there are about 75 million cases with 0.8 million deaths around that time. Retd came into picture, where India government decided to launch this National Malaria Control Program 1953. Then 1958, it was National Malaria Eradication Program. And that was a marvelous program, and it got the dividend. And by 1965-66, it was almost 0.1 million cases in the country, no deaths. And then 1976, there was a huge resurgence of malaria, not only in India, in whole Southeast Asia countries. India alone had 6.4 million cases of malaria. And the, beginning of NIMR or MRC that time, it was July 1977, a government decided that research support must be there with the program. So I was the initial stage. You can see the first few pillars of NIMR. And then I was lucky to work under Dr. Divendu Shekhar Chaudhary. Dr. Divendu Chaudhary, we call. And Dr. V.P. Sharma, he was there, That time, what research you should do, because Dr. Chaudhary was the first scientist in India to in vitro culture the malaria parasites. Was the first scientist in India to grow P. malariae in vitro. Then he started working on P. falciparum, and we are the laboratory in the country those days, only laboratory who were growing P. falciparum in vitro culture. And that time I joined as research scientist, research fellow, research fellow under ICMR. And I had given training so many scientists from our institute to, promote this malaria research. Many, like PGI Chandigarh, then St. John's Medical College in Bangalore, and Lucknow King George Medical. Many, many scientists, they came to us. And then Dr. U.B. Wag from Pune, he was there, Dr. Jacob John. So, there are a lot of good scientists around. I came in contact. So that gave me one, inputs for, going for science, for malaria research. And the time I joined in 1980s, lot of outbreaks were around Delhi, like Sonipat districts and all these places. Even Delhi also, outskirts of Delhi also, there are a lot of malaria outbreaks were there. And then that time there was no diagnostic method. So we used to go early in the morning, collect the mosquitoes, like Anopheles calypsis. We used to collect from Sonipath, and we used to dissect them, and then we used to get sporozoites, very lively sporozoites. And then me and Dr. Chaudhary developed a kind of modified technique for staining the sporozoites. First, and that helped many scientists afterwards, because you get sporozoites, but while staining you don't find, none is there. We had developed a modified technique of sporozoite staining, because I believe, this is the, backbone of malaria. Dr. Chaudhary used to say, if you are a malariologist, two aspects you understand. One is that parasites, and another one is the vector. These combinations should have for every malariologist.
True.
Or say vector biologists. Suppose you are working on lymphatic filariasis. So you should understand the filaria parasite and also the vector. How do they grow, and what are the parameters? What are the things influence the, they are growing inside the vector. And then epidemiology aspects is very, very important. Yes. So my thesis was on that aspect only those days. And, molecular tools were not, very, developed that time. And then, some serological tests were there, because that time scientists, they were working on malaria serology. And diagnosis was a big challenge even those days also. Only microscopy was there. Still today, I believe the microscopy is the number one. My knowledge goes, because I have 42 years. I know that my microscopy cannot keep aside anytime in the face of malaria research.
True.
So then came gene cloning, and gene cloning, David came from Australia. He first started falciparum gene cloning. And I was fortunate enough to work under him for some time in ICGB. When ICGB 1990, he came as a faculty. So I learned gene cloning from him, molecular parasitology. And then, in 1990s, what was happening? That Malaria Research Center that time they took up a big project called Bioenvironmental Control of Malaria, Integrated Disease Vector Control, IDVC. It was the under Science and Technology project, huge project. And then NIMR had established about 8-10 field units throughout the country, because malaria is a focal and local disease, so it depends on the local vectors. In India, there are 10 vectors, and 65% of the malaria in rural area is transmitted by Anopheles staphylococcus.
Yeah.
Fine. And all urban malaria is Anopheles staphylococcus. In India, I'm talking in Indian context.
Yes.
Fine. So that was very, very critical situation. So I was immediately joined as research scientist from that project. And then I was posted in Rourkela. There was a field unit. So I was the scientist, established that unit in Odisha. And that was called tribal malaria. And first time we reported also, that the malaria is hugely underreporting.
Yes.
And that actually opened the eye of many, many program people. So if you find, not even 10 times or 20 times, it was more than 100 times.
True.
And if you don't know the disease burden, okay, so then you cannot take any action plan or strategic plan. Suppose you don't report any disease as such.
Yes.
Then no diagnosis, no case reporting, and you don't take any. But under the line, you are having a lot of malaria. When I was working 5 years in Rourkela, then I reported that asymptomatic malaria cases.
Yes.
And asymptomatic malaria cases, actually, it was about around 20%.
Wow.
Those days. And when I was reported that, it was a huge, debate came at that time, that whether it is 20% or, I say, You can come down to the unit. I can show you the children. They are just playing, and you can catch them. You can draw the smear. You can find this parasite in them.
Parasite. Yeah.
And one basic aspect, I think these days nobody is talking of real malaria epidemiology. I'm very much unhappy on this because Dr. Choudhury taught me how to check the spleen in children. If you malaria epidemiology, there are like holoendemic, hyperendemic, mesoendemic, hypoendemic. There are classes of endemicity,
Yes.
and based on the children, 2 to 9 years children, splenomegaly.
Yes.
So when we were in Raukela and Dr. Choudhury and me were doing this survey, and he used to check this spleen, and he taught me how to check the spleen. Very simple thing. And you don't believe it, that first time we reported that in Odisha, what is happening, it is equivalent to any African countries, highly endemic African countries. So it was highly holo-endemic situations. So the thing is that until we understand that kind of background, you cannot give any kind of uh, control strategies and all these things. Then came to vector biology. So in Odisha, we found flu atlas, vector incriminated, and also Pilusipesis we found also, we also incriminated. Another thing I did simultaneously, that we had a clinic in our unit in Raurkela. You don't believe it. Some filaria, lymphatic filaria cases around the township was there, about 10% MF rate, microfilaria. And when we checked those patients in our clinic, some patients they had elephantiasis, and then we had a special survey afterwards. And you don't believe it, some patients they had malaria also, and they had filaria also. So then what we decided, that first you have to screen the thick smear of the blood for 10x objective for filaria, scan it, and then you go for the 100x examination for malaria parasites.
10x. Yes.
So co-endemicity, filariasis and malaria, both were existing in the fringe of Raurkela town. So that was one finding, concomitant infection. We published also that so it opened eyes. Not only that means the vector-borne diseases are a very complex thing. So then a lot of activities, and now control activities started, and all this happened. While I was working in tribal malaria, so based on the reporting on that, and then we, there we got, malaria also, plasmodium malaria. So about 1% plasmodium malaria, and almost 19% Vivax, and 80% you can say about falciparum. So even today, if you see the whole malaria picture in the country, in India, if you take it from the Western Ghat hill range to Central Ghat to Eastern Ghats, to Satpura hill range to Chotanagpur hill range, this whole range is tribal belt, and that is full of falciparum malaria, and that is the challenge. Today in India, we have 24 districts in 8 states, tribal states, 90% malaria now, as per the report on 1921.
Yes, sir. So when you got all this training from the experts, in their field and the leaders, when now you were leading the team, how did you see that the epidemics, or the infections, because people do talk about mixed infections in malaria also, what are the things which you think are lacking? And with all the technology available, although like parasites are also getting more smarter, mosquitoes are getting more smarter, it is tough to tackle the malaria. But when now people are already starting about talking about eradication, malaria eradication. What are your thoughts that what are the ground realities, what people have to consider before, saying or aiming for eradication?
See, there are two differences I tell you, eradication and elimination.
Mm-hmm.
Technically, these two terms are very distinct terminology. So
True.
today you're talking of elimination, not eradication.
Mm-hmm.
Elimination is that there will be no indigenous transmission.
Mm-hmm.
That means zero transmission in a particular locality. I'm talking of what WHO says that in India, it is not a country, it's a continent. So
Mm-hmm.
India is governed by, many 10 mosquito vector species. Fine. So if any state can, eliminate malaria, that state can be declared as malaria free or elimination free. For
Mm-hmm.
that, zero cases for consecutive 3 years.
Mm-hmm.
Then WHO will come, they will find, yes, there is no zero transmission malaria. Then they will certify, okay, this area or this country is free from malaria. So since 1900 until 2023,
Mm-hmm.
29th March 23,
Mm-hmm.
129 countries has been able to eliminate malaria. And 2016, Sri Lanka declared elimination of malaria. But
Mm-hmm.
Sri Lanka is facing 2017. Now they are reporting of Anopheles stephensi in
Yes.
Sri Lanka. And that is a different talk I will give you later on. Anopheles
Mm-hmm.
stephensi is a great threat, which is Asian mosquito vector, Southeast Asia to Middle East countries. Now it has invaded Africa. So I will
Africa
talk
also.
on that.
Yeah.
Africa. It's a huge problem in Africa.
Mm-hmm.
So the coming on the point, that these days, what actually happened, I tell you,
Mm-hmm.
whatever the bioenvironmental control of malaria NIMR has initiated, that gave a huge dividend, I tell you.
Mm-hmm.
Beginning of 1985, there are a lot of, efforts were made to control or to have a containment program on the vector part, not the disease as such. So if you have vector control program on the ground level, at the community level, that gave us the huge dividend generally. So what you see today of malaria elimination,
Mm-hmm.
that is because of the National Institute of Malaria Research contribution. I say there is no doubt on that.
Mm-hmm.
So environmental control malaria gave us the idea that how to tackle the local situations.
Mm-hmm.
Like we had a unit in Haridwar.
Mm-hmm.
Haridwar, there was some outbreak of malaria for decades. Fine. And because of the lot of ditches around of the and the fly ash of the thermal power plant, it was
Mm-hmm.
filled up with the fly ash around the township and every make and around that it
Mm-hmm.
eliminated malaria.
Mm-hmm.
So that the concept of vector sanitation, which was the beginning of pre-DDT era,
Mm-hmm.
that actually a permanent solution for all these things. If
Right.
I go to the more history before that, now coming to the point, how I was posted in Bangalore unit of NIMR in 1994. So what happened that, Bangalore is the capital of Karnataka. And
Mm-hmm.
Karnataka is a erstwhile the Mysore state.
Mm-hmm.
So 1st November 1956, Karnataka became a state. Earlier, it
Mm-hmm.
was called princely state Mysore.
Okay.
Okay. So now what happened? 1992, our Bangalore unit was established to the request of the government of Karnataka
Mm-hmm.
to address a very, serious issue. The issue was in and around Bangalore, Karnataka, like Kolar district, like Ramnagara district,
Mm-hmm.
then Tiru district, Hassan district, Mysore district, and including Bangalore rural districts, there are huge sericulture,
Mm-hmm. Yes.
you know, And sericulture is very much a cash crop. Not only it is a very sentiment, because the Mysore silk is a very famous silk. Natural Mysore silk is produced from mulberry silk. These caterpillars are grown on the leaves of the mulberries plant. And everywhere, I just, when I posted here, and then I was traveling around to understand the local issues, that local situations, See, I did the situation, and I say every scientist go for situation analysis.
First.
And then come down to the basics, find out the real problem in those areas. Then until you understand the real problem, you cannot, address that issues. So when I was studying all these places, and then telling my fellow colleagues, scientists, that, I didn't find much differences of geographical situation like what I was finding in Rourkela, because there are a lot of hillocks around, then streams around them. And then I said, it is very difficult to, control malaria without insecticide, because sericulture means you cannot spray a single gram of insecticide, though program was doing. But the problem came, people are not at all cooperating in the program. So they were refusing. And I have seen many people are agitated because they are losing their, earnings. They say, we don't have, we have malaria, we know, but our earnings, our everything coming from this sericulture. So we cannot, compromise with the, destruction of this sericulture. Now tell me, those days, there are many things we on the, had debated. We had brainstorming sessions, what should be done and all these things. And then we found very interesting thing. One big science came out after that, then how to do that? Because we found, first time, we found Anopheles calypsis is breeding in the wells. So the local area is like that. There are villages. Around the villages, there are a lot of, there is no river and belt. So there are a lot of open dug wells for the agriculture purpose. And basically the agriculture is this, vegetables and, this, and some they also grow a lot of mulberry leaves and plants for their sericulture purpose. And also these sericulture plant, whatever the, excess was coming, they had cattle population, huge number of cattle population supporting for milk. So silk and milk is famous for this area. So the thing is that now you have to find out a solution for them. So one thing, I just was traveling, and then, that area is a very adjacent area, is that Kolar Goldfield.
Yes.
So Kolar Goldfield is one of the oldest mine in India. Goldfield, I think, is started in 1986. By the time Sir Ronald Ross discovered malaria parasite and all this role, mosquitoes role of malaria parasite transmission. So that time, what happened? This Kolar Goldfield was initiated, and a lot of malaria also around. And then I researched the literature that this guppy fish was brought to India in 1908 to control malaria.
Okay.
Yes. Then I was telling my boys, look, other side of this, primary health center, there is a huge, big primary health center. India has got a beautiful primary healthcare system. And then primary health center, one side, their sub-centers are there. Out of 11 sub-centers, 8 sub-centers had full of malaria, and 3 sub-centers no malaria. I said, okay, first to find out why 3 areas no malaria. No malaria. We know for 8 sub-center malaria, what is the reason? We found flu fleas, we found calypsis. There are major 2 vectors are there. Fine. Then when he's searching for that no malaria reason, then we found that tracks of Kolar Goldfield, that entire track was there, full of guppies. And that gave us the first lead. In terms of guppies, there is no malaria at all. And unfortunately, that was a big barrier. It never came into the, the other side of this primary health center. Very unfortunate. If it has been connected with the colored goldfish channels, hopefully this area also would have been free from malaria. And then what we did, and then the director asked me that you tell me what we should do. I said, sir, before I joined the center, so they were planning to have channelization of the streams. If you have kind of check dam and then flushing of water and all these things were there. Then what another important aspect is that, and I really thank the government of Karnataka, they had whatever we wanted, they have presented their whole data to us. Then we took the entire village-wise data of the primary health center. 100 and I think 3 villages. We scanned all these villages, and then one very interesting thing came out, that the villages having more number of wells have more number of malaria, and the villages with streams very less malaria. Very distinct pictures. So this is situation analysis that helped us a big way. Big came out. Raja. So we caught mosquitoes and then we sent to Delhi for genetic analysis. You don't believe it. Our NIMR is the center for WHO's for sibling species studies of vector mosquitoes. And then we found that villages surrounded by the wells, 90% were species A of Clusiophysis, which is the most efficient vector, But other side is species B, just reverse. Stream villages with 90% species B, 10% species A. So there is hardly any malaria transmission. So what is the reason? That means species B is a refracted to infection to malaria parasites. And is highly susceptible to species A, and that proved afterwards is true. So there was studies afterwards came. NIMR took a big study. They colonized the mosquitoes. They did experimental studies, and it proved that species B is a very poor vector as compared to species A. And because my observation here in Karnataka, a big science came out, and then I published this paper in Transaction Royal Society with the help of Professor Chris Curtis. He was following our work from London and many platform, many seminars, symposia, conferences. I had presented this work, and then he was in touch with me, and in 2004. There was one global meet on parasitology, third global meet on parasitology. He was invited. And then Chris Curtis, he said, tomorrow I am whole day free. Can we have a visit to your area? You are telling. Then I talked to the local authorities and then they only arranged that his trip for the whole day. And when he came back at the late evening, he was surprised. He said, absolutely, you have mesmerized. You have taken a new science that how larvivorous fish can control malaria. With my own eyes, I have seen. And I have written one article in his memory in the Transaction Society afterwards. When he left the world, I published that article in Transaction Royal Society.
Sir, here we want to know that with your more than 5 decades of experience in malaria biology and doing this, the way you have dissected the epidemiology, this observation, what you can suggest our upcoming researchers that now they are the one who has to face this, changed stage of malaria in India. Yes. What are the things they should be more focused on, or there are the things which has changed over the time, because you have seen pre-DDT to post-DDT and now pyrethroids. Yes. You did a great job with the larvivorous fish also. Yes. What are your suggestions for them that they should focus on?
See, my suggestions to this new generation that, you must dissect the situations and find out the real issues. What are the research questions? What are the research, real issues? even you are doing a lot of efforts and intervention and all these things, why you are not still able to, contain malaria or say control malaria? What are the issues? You have to enumerate those issues. For that, you have to go in the field, camp in the field, stay with the villagers, then ask them. I think, these days children are very intelligent, I tell you. And only this mobile era or internet era, whatever the things, I was in Mangalore, it's a city, coastal city, and I was given kind of a, joint meeting, and press people were also there. And what I was telling them, you don't believe it, immediately they were checking through internet whether I'm telling correct or not.
Yes.
That much of knowledge has come to the people. So I have learned many things from my every field visit. I have learned every field visit I have learned. So I suggest them, malaria is a disease, is a public health issue. Go to the field, understand the community dynamics, mingle with and you don't believe it. I never stayed in hotels in those villages. I used to stay in the village. And our boys, they adapt local food. They adapt local food, local culture, and they mingle with the people. They were trying to understand what is the real problem. And we found many solutions from the communities, I tell you. So that kind of interaction, these scientists, they should understand. So you are doing a lot of good work on molecular biology, basic biology, whatever it may be. Until you understand the real issue, you cannot find out a solution for that. So you ask me other questions. What are the real issues these days? Now the elimination. 2016, I think 11 or 12 February, India launched malaria elimination framework, National Malaria Elimination Framework in February 2016, with the aim to eliminate malaria from India for 2030.
Okay.
Now, where do you stand today? If you see the whole data as such, I'm giving example of Karnataka, where I have done almost, say, 30 years now. When I joined 94, that time the malaria cases was above 85,000 cases. Only Karnataka alone. 2022, 279 cases. So now the question is that how it happened. It didn't happen overnight. It happened over the years with a, and in between, with my help, the government of Karnataka, they recruited medical entomologists. They are the backbone of any vector control program. I have written a blog with the request of India Health Fund. You have that. I have written a special section on that, need of medical entomologists in the country. For the last 30 years or 40 years, we do not recognize the role of medical entomologists. And they are the pillars, they are the backbone. And since 2000 onwards, Government of Karnataka, they recruited medical entomologists, and NIMR being the field unit chief, I used to have interactions with them. We gave them training, and training means, whenever you have our program in the field or any research activities, so I used to involve them, all the entomologists, to come and join our team. You learn on the practical field. And today I'm very happy that whatever I have given as a mentor, what I have taught my predecessor, mentors, now the fruits are gaining.
Nice.
And
Very
that
good.
is the biggest contribution, what I can say to the next generation, that these are the torch bearers, and they are excellent job they are doing. And I am touching each and every entomologist in the state, not only in the state, many entomologists in the country, and I advise them what they should do, what they should find out to find out the solutions, because everything depends on the local situations.
True. And it is different for every state when you're
Yes,
changing the vector species, the
yes.
demographics. So this is a very great conversation, sir, with you. And I would like to tell all the audience here that Dr. Ghosh is a great mentor. If you have any question, if you want his suggestion, his opinion about your work, he's always there to help you. Either you can write to Dr. Ghosh directly, or if you want Empowering Science Foundation to put you in touch with our researcher celebrities, you can write it to us also. With this small, conversation, although just keeping the time limits in the mind, I would like to ask, sir, the last question, that few takeaway messages from this conversation for people specifically who are working with malaria, but in public health. What should they focus the most?
The thing is that main focus I can tell you in today is the surveillance, is the
Yes.
backbone of anything.
Mm-hmm.
Second is the diagnosis.
Mm-hmm.
Today we are still facing a problem of malaria diagnosis. RD kits, the
Mm-hmm.
rapid diagnostic kits,
Mm-hmm.
based on HRP2, histidine reach protein 2, it is
Mm-hmm.
being failed. It is being failed everywhere. I was in Africa, Addis Ababa, and I
Mm-hmm.
was talking to the scientist, and they say, sir, now HRP2 is deleting very fast in their countries, and what next? They are now switching over to, parasite lactate dehydrogenase base. But again, there is a problem. Now the question is the diagnosis is there. So with my tenure, 5, 6 things I can tell you what I have done it. One is the digital based surveillance in
Mm-hmm.
Bangalore. It is
Mm-hmm.
that giving the dividend. It is a real time surveillance mechanism, and if
Mm-hmm.
it is used by
Mm-hmm.
the health workers or the diagnostic centers, you will get the real time malaria cases. It is micro PCR based, and I collaborated with the big tech company in Bangalore. Now they are producing as called TrueNet Malaria. Number one.
Mm-hmm.
Number two is the diagnose this surveillance I told you. It is a GIS based surveillance. Now point of care TrueNet Malaria, what I developed jointly, that is also giving a very good less than 5 parasites per microliter. You can do it. And also I am planning with them that we can develop also to detect the gametocyte carriage rate,
Mm-hmm.
especially high burden districts. Until you know the P. falciparum gametocyte carriage rate, we cannot, you know, uh, cut down the residual transmission.
Mm-hmm.
Number three is that community engagement is very, very
Yes.
important. So I did a program called folk theater based, community based, health education program, and that gave a huge dividend. That publication I have already done.
Mm-hmm.
Second thing is that how we are going to do the inter. So I made one called block level task force for vector control, and which is now working in Karnataka. Block
Mm-hmm.
level task force where not only health department like Panchayat Raj department, other departments, forest departments, fisheries department, all joined together. A task force is formed and it is financed locally,
Yes. Wow.
self-maintained. Yes.
Mm-hmm.
And now the government of India has called wellness center. So there are
Mm-hmm.
every panchayat they have got what we call health committee.
Mm-hmm.
We have to empower them, these people. We have to
True.
empower the policy makers.
Mhm. Absolutely, absolutely. And
Yes,
I think that is the role of all the public health worker. And
yes,
as you clearly mentioned about surveillance, diagnostics, and
yes.
community engagement, these
Engagement.
are the pillars where we have to rely on to get rid of malaria, or
Yes,
as you say, eradication or elimination. If we have
yes.
to work towards it, we have to follow these basics. Thank you very, very much, sir,
Thank
for
you.
taking time out and sharing the
Thank you so
journey
much.
with all the young researchers. I'm sure that they are getting benefited out of this. And just one note, that in true means, every single researcher is a celebrity, but giving the time which you have given to the field of research and helping so many lives, that is what makes you a real celebrity. Thank you very much for sharing this journey with us, sir.
Thank you so much. Thank you so much. Thank you.